There we go. And yes, I am recording audio. Okay, good. So let's talk about orthopedics. Ortho is a root word that means bone. Pedi refers to children. Think of pediatrics. Orthopedics originally started out as a branch of medicine that focused on the bones of children. And there used to be lots of bone disorders in children, in particular because of poor nutrition. Orthopedics is now expanded to include a lot more than just children. One of the largest branches of orthopedics right now is joint replacement, or arthroplasties, to replace an arthrosis or a joint with a fake joint, typically that has some plastic in it, is referred to as arthroplasty. One of the most common treatments my wife works with is individuals that have had a total knee arthroplasty, or TKO as she refers to them as. So, as we look at our bones unfortunately break every now and then. I've broken 3 bones within my lifetimes, and there's been different ways, different times. As we break our bones, generally speaking, it's going to be a stress fracture, and this stress fracture is going to be the most common way that we break a bone. It's from blunt physical force. If you hit the bone or stress the bone to break the bone, it's a stress fracture. And this is differentiated from a pathological fracture, which is a break related to some homeostatic imbalance. It could be a lack of calcium in the diet. It could be a lack of vitamin D. Maybe there's excessive parathyroid hormone, so the individual could have a pituitary tumor, a tumor of the parathyroid gland, and they're upregulating parathyroid hormone. There's lots of different things. Sarcomas, bone cancers, an osteoma, a bone cancer, is also another common pathological fracture, particularly if you have a perfectly healthy individual who gets bumped and they break a bone. That's a red flag. They might have bone cancer.
So is bone cancer sarcoma or?
Osteomas. Osteoma, yes. Sarco is for muscle. Osteo is for bone. So as we look at these different kinds of fractures, we can have displaced or non-displaced. And as you're studying these terms, I want you to group those in your head, displaced versus non-displaced. When it's displaced, we have shifting of the fragments. Non-displaced, the fragments are still going to be aligned with each other. If you had to pick what kind of break you want a non-displaced break through your bone. They tend to heal the quickest and the easiest. If it's displaced, the bones need to be realigned before they can heal properly. And if the bones are not realigned and they heal incorrectly, there's only one solution, and that's to re-break the bone, realign the fragments, and then let it heal correctly, hopefully the second time around. If there is a comminuted fracture is when you have a shattering or fragmentation of the bones. The comminuted fracture shown in this picture, or in this slide, is going to be in the lower left-hand corner of the screen. That individual has had their bones completely shattered. We also could have a green stick fracture. Green stick fractures are typically associated with young children or pre-adolescent individuals. And this is going to be a fracture of somebody who has a very high concentration of collagen in their bone, but they don't have a lot of the minerals built up in their extracellular matrix yet. The green stick fracture is named for a green twig. And if you've ever taken a green twig and tried to snap it, you usually get all these little fibers and fragments, and that will happen with the green stick fracture as well. It's going to be an incomplete or partial fracture. We also have a compound fracture. Compound fractures are also known as open fractures. Compound fractures are also known as open fracture. Open fracture is the new school name. Compound fracture is the old school name. If it's a compound fracture, you have a chunk of broken bone sticking out of the surface of the skin. So, you break a bone. Let's talk about healing the bone. This is where the periosteum plays a very important role. Remember, the periosteum is that membrane that wraps around the outer perimeter of the bone, and that periosteum is going to capture the blood. The transverse canals and the central canals of the dense bone tissue have lots and lots of blood capillaries in them. And when we fracture our bone, we sever many thousands of blood capillaries. Those blood capillaries ooze blood, and the periosteum collects the blood to form a blood clot. That blood clot is then going to turn into cartilage. So for step one, clotting forms, or we form the hematoma. Step two is that we're going to have that clot turn into cartilage tissue. And we'll have multiple cartilage tissues form, the most common of which is going to be fibrocartilage, but there'll be small amounts of hyaline cartilage as well. That cartilage tissue will then be ossified by osteoblasts, primarily from the periosteum. But there are small amounts of osteoblasts present within the endosteum of the medullary or marrow cavity of the bone as well. As that hard callus forms, we then need to restore the medullary cavity. And the osteoclasts, which are present within the endosteum, that membrane that lines the inside of the cell, will then dissolve the middle portion or the inner portion of the hard callus and then restore function. Now, I need to really emphasize for you right here, after you break a bone, that bone is thicker where you broke it. And this is one of the reasons why individuals almost never break a bone in the same spot twice. That really big blood clot turned into a really big blob of cartilage, which turned into a really thick segment of dense bone tissue at the site of breakage. This is one of the reasons why sometimes you'd hear people breaking their knuckles on purpose so that they could have a harder punch or things of that nature. When we look at how to treat broken bones, we can have closed reduction or open reduction. When we look at the closed reduction, this is going to be manipulation, physical manipulation of the bone with palpation and traction, pulling on that bone to realign the fragments. Closed reduction is typically going to be used if there's two fragments to the broken bone. Two or less, because we could have a green stick fracture, which would typically only have one piece that's still broken. Now, if there's multiple broken bone fragments, if we have a commuted fracture, to get those multiple bone fragments to align properly, you're probably going to need to have some surgical pins installed. And that's going to be known as open reduction. Sometimes those pins are going to remain completely buried within the soft tissue. I have 5 screws in my knees right now. Sometimes we'll have some of the screws above the surface, and there'll be large metal apparatuses on the surface of the skin. The best man in my wedding, when he was 19, crashed his Chevy Cavalier into a snowplow at 60 miles an hour. And he had all kinds of crazy chunks of metal on the surface of his arms because he had many, many bone fragments throughout his body after that car accident. When we think of the cast traditionally has been made from magnesium sulfate, and it's really old school. We almost never see permanent hard casts anymore. They're falling out of favor, in particular because of the hygiene reasons. Out of curiosity, has anyone here had the traditional plaster cast? How bad did it smell after 6 weeks? It's just disgusting. So what we find now is that removable Velcro casts are becoming much more common. They serve the same purpose. They immobilize the joint and allow for soft callus and hard callus formation, but you can still shower. So it's the best of both worlds. Sometimes we need to apply mechanical force to the bones to help them heal correctly. Oh, question, comment?
I was just wondering, I don't know if it happens, but you break a bone and you shatter it. I always sometimes heard the pieces just can't put them back together.
Good question. If you break a bone and shatter it, is it possible for the pieces not to go back together? The answer is yes. Particularly if you have very small fragments of bone that weigh less than a gram, those very small fragments of bone will be just removed surgically. There are other complications that are associated with this. If you have particularly a break of the femur, you have really large muscles associated with the femur, and those bone fragments in the thigh can tear the muscles of your thigh and cause a lot of internal hemorrhaging. So it's important to get those really tiny small fragments that you can't pin in place removed to aid in proper healing.
If they remove the fragments, do they just like regenerate, like shatter?
Yeah, there's a remarkable amount of regeneration that occurs. We also have thanks to an advance in ceramics, we now also have artificial bone that can be installed. So if there's lots of little pieces that we can't pin back together, we now have the ability to take cadaver bone and take the cadaver bone and give a bone graft so that there can be reestablishment of normal function. The same is true of cadaver tendons and ligaments. I have a couple of those. So let's talk about traction. When we think of traction, I want you to think of mechanical pressure realigning the bones. The classic picture of somebody in traction is somebody who's stuck in a hospital bed with their legs up in the air and weights hanging off of their legs and some pulleys. And when we use this traction, we typically are going to use it to keep the bone fragments aligned, despite the fact that there's very large muscles present that can shift those bone fragments. Individuals that are on traction, though, are going to suffer from a lack of physical activity. Think back to Wolff's law of bone remodeling, just bone remodeling in general. If you're stuck stationary, your bones aren't being pressured, you aren't moving around and stressing out your bones, and you start to lose bone density. So it's kind of a double-edged sword. The traction, if you're in bed rest, helps you to realign your bones for that broken bone to heal, but then you lose bone density across the rest of your skeleton because you're in bed rest. So in traction situations, it's used sparingly. Individuals that have hard to heal bones can be given a hormone that suppresses parathyroid hormone. Think back to Wednesday. PTH upregulates osteoclast activity. So if we suppress parathyroid hormone, our bone dissolving cells will be repressed, and our bones can be built up thicker quicker. Let's have a concept check. A fracture in which bone is broken into 3 or more pieces is called a blank fracture. Linear, pot, commuted, green stick, or compound. You want to flip back a couple slides. The slide with the 4 x-rays on it would be a good one to flip back to. Well, based on how quickly the answers are coming in, apparently this was an easier question, but we still have 10 seconds. The correct answer is a commuted fracture, and we did very solid on that question. Excellent. If we have 3 or more pieces, it is a commuted fracture. Let's talk about bone disorders, or some homeostatic imbalances that we can occur. We have osteoporosis. It's often mixed up with osteomalacia. Osteomalacia is thin bones because you never built up the bones in the first place. Osteoporosis is when you have thin or porous bones because you have taken too much out of them after you built them up. Pragmatically, osteomalacia and osteoporosis are the same thing. Your bones are very weak, but they're weak for different reasons. Now, as we look at osteoporosis, on the figure that I have on your screen, On the left-hand side, we have regular, healthy, spongy bone tissue. Notice how thick the trabeculae are of that spongy bone tissue. And then on the right-hand side of this figure, we have spongy bone tissue harvested from an individual that has had osteoporosis. And that individual has very few trabeculae compared to the healthy individual, and the trabeculae that remain are much thinner and much weaker. So if somebody has their bone tissue being demineralized, that's going to allow them to break their bones very frequently and very often. Oftentimes, students will ask me, why do people start to dissolve their bones? And, you know, it's a very legitimate question. If having weak bones is bad for you, why would your body dissolve your bones and reabsorb them? Why would your body do something to your skeleton that's bad for your skeleton? And the reason is, it's the least of multiple evils. Think back to the first chunk of this presentation, where we talked about what we use calcium ions for and what we use phosphate ions for. That calcium and phosphate we store in our bones' extracellular matrix, regulates blood pH. We use it for electrical activity in our brain. We use it to contract our muscular tissues. And I think if most people had to choose, they would choose having brain waves and a beating heart over having a strong skeleton. So is it good to have weak bones? No, it's not good. But it's better to have a functioning heart and nervous system than to have strong bones. As we look at individuals that could have some other malformations of their back, and actually I got ahead of myself with osteoporosis. So let's back up a slide here. One of the reasons why there's this stereotype of the little old lady in the nursing home, it's not because she's been short most of her lifetime, but what ends up happening as individuals develop osteoporosis is the vertebral body within the vertebral column start to compress. And they can lose several inches of height the last several years of their life because their vertebral column physically becomes shorter as it compresses under their own body weight because they lose their bone density. So let's talk about other disorders of the spine. Oh, question in the back. When does spine compression typically can you say that louder, please? When do you start getting shorter? That's a loaded question. It depends on your genetics, it depends on your lifestyle, it depends on your gender. Let's talk about some of the risk factors associated with that. If you have less bone density to start out with, generally speaking, your spine can start to compress sooner. And since females, generally speaking, have less bone density to start out with, they're more subject to having spinal compression. Also, sex hormones help to up-regulate osteoblast activity, both testosterone and estrogen. Males have functional testicles throughout their lifespan, most of the time, and will have that testosterone to help up-regulate their bone density. Females lose almost all of their estrogen after they hit menopause, and they lose a lot of their bone density when they become postmenopausal. And then there's also lifestyle. Do you drink your milk? Do you exercise? Or do you eat potato chips and hunch over a computer the whole time for hours a day? Those lifestyle factors also play a significant role. The one that I'm most worried about developing is kyphosis, because I'm a university instructor. I spend lots of time hunching over a computer monitor, and when I stand up straight, I always hear all this cracking in my back whenever I stand up, which is always concerning for me. Kyphosis is also known as the widow's hump or hunchback. We also could have lordosis. Lordosis is very rarely a permanent condition. It's temporarily present in pregnant women. If their center of gravity is shifted forward, they tend to lean back farther to help balance. Individuals that are very overweight or have a very large beer gut will also sometimes develop lordosis. More common is going to be scoliosis in young adults or young children. Scoliosis is the most common vertebral disorder of somebody who's under the age of 40. Scoliosis is going to be a side-to-side deflection of the vertebral column. Kyphosis is going to be abnormal curvature to the thoracic vertebrae, and lordosis is abnormal curvature to the lumbar vertebrae. So the question in the back was kind of jumping the gun. What influences osteoporosis and or compression of your vertebral column? The presence of estrogen and other sex hormones helps to maintain bone density by upregulating osteoblast formation. To treat bone loss and minimize bone loss, it used to be standard practice for postmenopausal women to be given an estrogen supplement, typically estradiol. But it was found almost a decade ago in a really large clinical trial that these estrogen supplements dramatically increase the risk of breast cancer. So almost immediately, the go-to medication for preventing osteoporosis in postmenopausal women was taken off the shelves overnight because most people would rather be at risk of getting osteoporosis than dramatically increase their risk of developing breast cancer. In terms of the demographic that is at the highest risk, it's going to be a postmenopausal white woman. We find that bone mass starts to decrease as early as the age of 35 in that demographic, just because of hormonal changes throughout their life cycle and some of the things associated with being Caucasian. If you're Caucasian, generally speaking, you live in a more northern environment or a more northern climate. And think of yourself this last winter. How much sunlight have you actually gotten over the last couple months? How much vitamin D did you activate so that you could absorb more calcium in your diet and help increase your bone density? Some other things that help influence the density of bone is going to be your body fat composition. One of the hormones that's typically not advertised or associated with adipose loose connective tissue is going to be estrogen. Adipose tissue gives off very low concentrations of estrogen. This is one of the reasons why individuals or young ladies that are very thin and have very low body fat compositions lose their monthly cycle because they don't have enough estrogen in their bodies to maintain their monthly cycle. And as they lose that estrogen associated with their body fat, their osteoblast activity will be downregulated and they start to lose some bone density. So, we used to give estrogen as a supplement. It's not very common anymore. There's still special cases, on a case-by-case basis where estrogen will be given. We find now that we're going to focus now on drugs that are either going to destroy osteoclasts. Remember, osteoclasts are the bone-dissolving cells. Or we're going to take parathyroid hormone and instead of giving that individual large spurts of parathyroid hormone from the parathyroid glands, one of the interesting things is that you have a very slow, low dose of parathyroid hormone. It actually minimizes the amount of bone loss. However, this parathyroid hormone derivative, Forteo, has been linked to osteomas or bone cancers. So it's not very commonly used. So what's the best thing you can do? Prevent osteoporosis. If you expose your bones to physical stress, they will remodel and become denser. If you have a good diet with lots of calcium, lots of vitamin D, and lots of vitamin C, and for the record, we use vitamin C to synthesize the collagen that the minerals precipitate onto. If you have the good diet and lots of exercise and upregulate your bone density early on in life, you have enough density to make it through the later stages of life without having the osteoporosis. So let's have a concept check. If we have a thyroid tumor that's secreting excessive calcitonin, so think back to calcitonin when we talked about it on Wednesday, 2 days ago, what would we expect? We talked about calcitrol, calcitonin, and parathyroid hormone on Wednesday. Calcitonin generally lowers blood calcium concentrations. So let's go ahead and check our answer, and let's talk through it too. If calcitonin lowers blood calcium concentrations, we find that it's going to upregulate osteoblast activity. Osteoclasts are cells that dissolve the bone and put calcium into the blood. So calcitonin is not going to upregulate osteoclast activity. If we look at endochondral ossification, if we're making bones, if we're ossifying our bone tissue, we are taking calcium out of the blood. Calcitonin is not going to inhibit that. It's going to promote endochondral ossification. If calcitonin lowers blood calcium, it probably won't raise it. And then finally, if calcitonin is lowering blood calcium, the part of our body we store that extra calcium we're trying to get out of the blood is going to be our bone. And our bone, generally speaking, doesn't become brittle when we make it thicker and stronger. That is it for bone tissues.